Okay, so thank you all for having me. My name is Dr. Leah Jones. Thank you for the wonderful introduction, Kelly, and thank you for the opportunity to have this very important conversation. So we're here to talk about how we can overcome treatment barriers for those who are African American and who need opioid use disorder treatment, and thereby increase outcomes for care. As many of you all will know, despite presenting, or maybe you don't know, is that African Americans present with more severe severity to addictions because they typically tend to present to treatment later. And despite the fact that they present, or we present, with greater addiction severity, we tend to have lower odds of initiating substance use disorder treatment. And after treatment engagement, we suffer from worse treatment outcomes, such as increased treatment discontinuation and continued substance use. I know that what we are experiencing now is a true disparity with regards to opioid overdose deaths. However, I don't believe that that has to be the future when it comes to opioid overdoses for our state, nor for our country. However, it's not going to go away just by wanting it to go away. We have to actually do something to make things change. And so we're here today to talk about the disparities in treatment for African Americans, to talk about some of the impacts of structural racism, and then look at the medications that we use to treat opioid use disorders and talk about the benefits thereof, which are certainly not exclusive to any one particular patient population. Provisional data from the CDC, when we could get data from the CDC showed that overall overdose deaths decreased by 10% in the 12 months ending in April 2024, which represented the largest decline in decades, which is phenomenal, particularly for families and communities and for those of us who've been working in this space for quite some time. However, the decrease that we're seeing is not being seen across the board in all patient populations. Whereas we're seeing a decrease in the majority population, we're actually seeing an increase in minority populations. And this is significant because, and we're looking particularly at the African American community because that's where we're seeing the greatest amount of disparities in deaths for Maryland, certainly. When you look at utilization rates of substances, Black people and white people use substances at the same rates. And so if we're using drugs at the same rates, you would expect that interventions that are targeted to treat the problem should be addressing all of our populations across the board, but clearly they're not. Opioid use, including both illicit opioid use and prescription opioid use, misuse, and overdose deaths among Black individuals are continuing to increase at alarmingly high rates. Differentially by gender, we know we're seeing this more in Black men, and it's also differential by age because we're seeing particularly more in older Black men. Overdose death rates have been disproportionately increasing in the Black community since 2010. And we have experienced the largest increase in drug-related overdose deaths compared to any ethnic group other than American Indian, Alaska Native, between 2010 to 2017. And our deaths certainly, as the deaths have increased across the nation with the advent or with the switch over from heroin to fentanyl, that increase or escalation and deaths certainly increased faster and more significantly in the Black community than in any other racial group. So when it comes to older men, overdose deaths have always disproportionately affected older Black men. This is likely a reflection of age-related health disparities, social isolation, and the consequences of a lifetime of exposure to structural racism. A National Institute on Drug Abuse analysis found that between 2015 and 2023, and this of course is provisional data, there was a nearly five-fold increase in overdose deaths among non-Hispanic Black men aged 55 and older. And that's what's demonstrated in this figure, in the figure before you. Most of these deaths were due to fentanyl and cocaine, and the overdose rate in older Black men is markedly higher than for Black men overall. So again, this is really a significant issue for older populations than younger populations. And this risk of problematic opioid use is raised by chronic illness. Pain is thought to be a significant factor, and we look at the treatment of pain is differential in our nation based by ethnicity, Black people's is not treated as aggressively as non-Black persons' pain is. Chronic pain is a prevalent problem amongst older adults. Um, and treatment for pain is differential in terms of effectiveness is not the same. The medications that we use for the older adults is not as effective as it is, or for younger adults is not as effective as it is for older adults. And so you have more untreated pain, which is part of the issue as well. And then we know that there are side effects that are associated with the treatment of pain based upon medications that are being used. And those side effects also cluster more for older individuals, leading to non-desirable effects from the treatment of from pain management. So what's the problem that we have in Maryland? One thing that we have seen, and of course we don't, we're not where we want to be. However, we certainly do want to celebrate any success that we're having in this space. And it certainly is wonderful that the number of overdose deaths amongst white Marylanders has been constant from 2016 to 2021. So, in order for things to get better, they have to stop getting worse. And so that's why I say that's a good thing that we're in a steady state, because that means that we can start seeing improvements. And I believe that more recent data shows that we are seeing improvements. But despite the fact that we have the steady state in one population, as I've mentioned previously, when it comes to Black individuals, we're not seeing that, and we saw that opioid overdose death rates have certainly increased in a differential way in the Black community, and that started roughly around 2016, 2017 or so. However, it does appear that we did enter into a steady state around 2020 for the Black community. So that in Maryland, which is a good thing, again, because we want to be going down and you've got to stop getting worse before you can start seeing improvements. But again, much like the nation, we're seeing the same issue. And though African Americans only represent 32% of the population in the state of Maryland, in I think the year here was 2023, we actually have more Black people die from opioid overdoses in the state of Maryland than white individuals, which is part of the problem when you look at differential deaths. There really shouldn't be any reason that this should be happening, and that it just emphasizes the significance of the issue. So what are the barriers to treatment? One of the largest barriers to treatment is certainly stigma. I like this definition of stigma. Says that people are stigmatized when the fact that they are labeled, set apart, and linked to undesirable characteristics, that alone leads them to experience status loss and discrimination, thereby affecting their life prospects, including income, education, housing status, and well-being. And stigma, I think what this communicates is that stigma certainly is more than a feeling. It does have real impact in the way that people experience their lives and experience care. And conditions can be stigmatized just like people can be stigmatized. And the impact of that stigma is a lack of appropriate treatment. When we look at stigmatizing attitudes amongst healthcare providers, and I'm kind of focusing this conversation around healthcare providers, we certainly know that there is stigma that is widespread amongst the healthcare treatment community, and that has detrimental consequences for connecting people who have opioid use disorders to treatment. Research has shown that stigma has been associated with a negative perception of treatment helpfulness and ultimately substance use disorder treatment discontinuation, particularly among African Americans. There is stigma associated with medication. So there's stigma associated with the condition, and there's stigma associated with the treatment for the condition. And certainly, as we all know, there's certainly stigma against medications like buprenorphine and methadone that seems to be grounded in the misperception that these medications are substituting one drug for another. The mindset being you're still an addict, you're just addicted to something else. However, what we know is that with effective treatment for opioid use disorders using medications, people who use drugs should not meet criteria for substance use disorders. They should not be using harmful substances in increasing amounts. They should not be spending a lot of their time securing substances or recovering from substance use. They're not giving up important social, occupational, and recreational activities because of substance use. They're not having negative life consequences. They are not in a mood altered state. They are fulfilling their major obligations at work, at school, and home. They're not using substances in a physically hazardous way. They're not craving, and they're not using substances overall. So it is truly not substitution. They don't meet criteria for having an addiction when someone is on medications for the treatment of a substance use disorder. To substitute is to perpetuate a problem. It's not to resolve one. And using medications resolves having a substance use disorder. It is a treatment. It's not perpetuation of the problem. Individuals with opiate use disorders prescribed methadone confirm that they experience high rates of stigma related to their medication use in interactions with the public and with healthcare professionals. And there's research that supports that. There was a study that was done in Richmond looking at patients who were on a buprenorphine program in an office-based setting. And they were asked had they felt that they were treated unfairly in getting healthcare services, not only because they were in treatment for a substance use disorder, but also because of their race. And what they found is that 1 in 4 participants reported substance use discrimination, substance use related discrimination, so discrimination because they had a substance use disorder, and 1 in 6 reported having race-based discrimination. And so these problems continue to be quite common in our communities. When we look at how it is that we think about people who have substance use disorders, word choice does matter. There was a national public opinion data study that was done back in 2010, and I know that that's a long time ago, but the study continues to be referenced, and I think which continues to speak to the validity of the data. And it looked at how people were described as either having a substance use disorder or someone who had who was a substance abuser, and they were asked different questions about, is treatment going to be effective for this person? Do they deserve treatment? Should this person be punished for having should this person be punished because of this problem? Does this person present a social threat? And based upon how a person was described as being a substance abuser versus a person who had a substance use disorder, people's reactions or responses to how these people should be dealt with varied, even though you're talking about the exact same person. And what we found is that if we use words like someone who has a substance use disorder, people were more inclined to believe these people deserved to be treated, that they shouldn't be punished because of their problem, that they were less of a social threat, that they were not the cause of their problem, that their problem was not their fault, and also that they deserved help to get to improve the problem. So it seems like a small thing, but it's not a small thing as the addiction community kind of struggles with and looks at how do we describe people who have substance use disorders? How do we describe treatment for for addiction? It is relevant to look at the words that it is that we're using, because it influences the way that we think about people who have these problems, and the way that we think influences what it is that we do. And so it is critically important that we focus on that. And so you have people who have these problems who enter into a cycle of stigma. So you have the public stigma associated with having an addiction. And there's also the public stigma that's associated with being in a minority population, discrimination, prejudice, and fear that people experience, the damage to self-esteem and hopefulness, and treatment avoidance, which leads to perpetuation of the self-stigma because the problem continues, which leads to self-shame and doubt, which also leads to continuation of the problem, and then lack of engagement, reduced recovery rates, increased rates of dropping out from treatment, and then again, continued use of substances. And so it really is a cycle that needs to be interrupted, and hopefully conversations like this will help to interrupt these cycles of stigma. What we do know is that addiction is not portrayed the same in all communities, which continues to add to stigma. the opioid abuse or the opioid use epidemic in the United States is not the United States' first experience of widespread drug use and addiction, but it certainly is the way that the country has responded to the opioid crisis that we're calling this now certainly has is very different than how we responded to the war on drugs during the war on drugs era, where we had very stringent sentencing and vehement drug criminalization in the 80s and the 90s, which proved drastically damaging to Black communities and certainly was ineffective in helping to solve the problem. Whereas when we look at how we are looking at the opioid crisis now, and certainly the way that we were originally talking about this problem and who was portrayed as having the problem, it was largely white voices that we heard about patients or people and family members who had opioid addictions, who were being portrayed as victims of these wild prescribing practices. And rather than how their Black counterparts were being portrayed and continue to be portrayed as persons who have moral failings. And we have these deaths of despair versus the concept of there being natural consequences of being a drug addict. And the tragedy of what happened to a person versus, oh, well, what did they expect to happen? They deserved it, that attitude. But we all know that it's the same disease, no matter whose body occupies or whose body occupies the disease. Our attitude, therefore, should be the same, one of empathy and compassion at baseline. And if we don't have an attitude of empathy and compassion at baseline, then we really need to look at our own prejudices. And the reality is that we all have prejudices. By tying populations that are already negatively stigmatized to substance use, media representations contributed to and continue to contribute to and reinforce negative attitudes amongst the public towards people who have substance use disorders. And there is evidence that bears this out. There was an experimental study that showed that attitudes towards people with opioid use disorders were more positive amongst people randomized to read a narrative about a woman with an opioid use disorder of a high socioeconomic status compared to those randomized to read about a woman with opioid use disorder and a low socioeconomic status. And we see this, I mean, even without looking at a study, you look at how it is that we look at superstars who have substance use disorders versus someone who is destitute and on the street who has the same disease, but the way that we perceive them as an individual and their inherent worth and whether they should get help or whether they deserve to get help or whether it's their fault or not, it changes based upon who it is that we're looking at. And that has significant impact amongst individuals who are African American. And when we look at, and I insert this opioid use disorder cascade of care visual here, not because I'm going to speak about this, but what I want to speak to is the fact that these are all the different places where people can be identified as having an opioid use disorder and where people can be recommended or referred to treatment. And I assure you that if you look at every single one of those systems, you're going to see that there are disparities in outcomes and disparities in how people experience services in all of those different settings. And so when we look at how do we address structural stigma, we need to look at it across all of these different settings and not just the one-on-one individual interaction between a person and their treatment provider, as those of us who work to improve systems and how people experience systems of care. And we certainly know that the drug war drove mass incarceration and racial disparities in the United States. And I mentioned earlier that and this graphic, this bar graph speaks to the fact when you look at utilization of substance use, Black individuals and white individuals use drugs at similar rates. However, when you look at outcomes from that substance use when it comes to interaction with the criminal justice system, you certainly see significantly higher increased rates of incarceration and interaction with the criminal justice system if you are a Black individual who uses drugs. Though arrest rates have changed in more recent years and across the board, we still continue to see a perpetuation of a disparity in arrest rates that leans heavily towards African Americans being arrested as opposed to their white counterparts from a comparison perspective. So this continues to be a problem. And then when you look at treatment outcomes, what we know is that anyone who's provided to high quality care, no matter who it is that they can get better. And so here is where we need to continue to push. And we certainly know that there are certainly lots of drivers for disparities in access and outcomes that are a result of structural racism. And what do I mean when I say structural racism? I'm talking about the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, which we know we see issues there, education, we see differences there, employment, we see differences there, earnings, benefits, credit, media, healthcare, and criminal justice. We see perpetuation of discrimination in all of these different areas. And so that is what I'm referring to when I talk about structural racism. And these patterns and these practices reinforce discriminatory beliefs, values, and distribution of resources. And the negative, and it's certainly thought that the negative consequences associated with substance use disorder are worse for Black people because of structural racism, not because of some biological differences, not because of moral failings, not because of all of the things that people historically have said as the reasons why. Those are not the reasons. It really does boil down to who has access and who does not have access to care, and why people have access and why they don't have access to care. And so this is an example of what that looks like. And so we certainly we see that there continues to be a decrease in the number of people who are treated for substance use disorders. This is a more recent study done in 2021 in Allegheny County in Western Pennsylvania. And they showed that individuals, pardon me, should go back. They showed that Black individuals with opioid use disorders were less likely to, keep going. I like that. I like that button. We're less likely to enter treatment, less likely to receive medication for opioid disorder treatment, less likely to complete residential treatment, and less likely to remain in treatment for a year compared to their counterparts. And we know that the standard recommendation is that people stay in treatment at least for a year for using medications for the treatment of their substance use disorder. When we look at an even larger study looking at Medicare data, this is from a JAMA paper in 2023. It showed that, 2023, looking at 23,000 beneficiaries of Medicare who had opioid use disorder symptoms, there was a differential rate of prescriptions for those who were white versus those who were Black. And so events is referring to treatment, whether that be medication or referral, or treatment, period, different types of treatment. And so they showed that there were differences in receipt of medications, and that were not explainable by sex. They were not explainable by the number of interactions or appointments that people had with providers. They were not explainable by anything other than the fact that than race in this particular instance, because they looked at all these other variables and showed that Black recipients of buprenorphine, they received lower amounts of medication when they did get medication compared to their white peers, but overall they got they were less likely to be treated than their peers. And unfortunately, we also see the same data when we're talking about pregnant women. So pregnant women who have opioid use disorders, if you are a Black woman with an opioid use disorder, you're less likely to get medication for the treatment of your addiction compared to your white counterpart. So this was done at Mass General. And then looking at in the South, this one, I think this one comes out of Vanderbilt, this paper. They were looking at the fact that it wasn't based upon education status. So if you were a Black woman who had an opiate use disorder, regardless of your education status, you were less likely to be treated for your opioid use disorder. And we all certainly know that people who are incarcerated have a very significant rate of opioid overdose deaths. It's one of the most significant causes of death when someone's released from incarceration. And why is this important? It's important because, again, I talked about the fact that African Americans are more likely to be incarcerated. And so it's no surprise that you're going to see more Black people dying from opioid use disorder overdoses because they are incarcerated at disparately increased rates. And when they are released from jail, they have a drastically, and everyone has a drastically increased rate of opioid overdose death when they're released from incarceration. So what do we do? There's a lot that we can do. The most important thing I would say is that we do have to understand and appreciate the history of Black people in the United States of America as it pertains to disparate treatment and outcomes. We have to appreciate and learn the strengths of this culture and leverage this in the design and delivery of programs, services, and funding. We have to demand, as healthcare providers, we have to demand equitable health outcomes for those that the communities that we're caring for, the individuals that we're caring for. And we need to push for solutions as if our individual loved ones, as if our individual communities were on the receiving end of any particular intervention. And to that end, one of the things that we did to try to address this problem in the state of Maryland was to create the Maryland Racial Disparities and Overdose Task Force, which is a task force that I chaired as Deputy Secretary from 2021 to 2022. And the purpose of the task force was to address the growing rate of opioid overdose deaths amongst Black Marylanders. I was grateful to be able to lead this work and for Maryland to, and my goal was for Maryland to be a front runner in this issue because it was an important thing for us to address. And I appreciated the support of the Lieutenant Governor at that time, Boyd Rutherford, in leading this work. So I won't speak too much about this other than to say that our recommendations were that we expand low barrier and holistic access to treatment services, that we reduce stigma for people who use drugs, that we increase harm reduction in non-traditional settings, and that we increase transparency in state and local resource allocation. And to the with regards to expanding access to treatment, relevant to this particular audience, the importance was increasing buprenorphine access for more Black Marylanders. And we thought that one way of doing that would be to increase the comfort with medications for opioid use disorder treatment, increase comfort of prescribing these medications by those who are able to prescribe them, and investigate barriers to prescription for those who are able to prescribe these medications. And additionally, we recommended the expansion of trauma-informed care and treatment settings because we know that it's important that when individuals engage in treatment, that they are treated in a respectful and person-centered manner and ensure that they were not re-traumatized in the process of seeking care, which only pushes people out of services. Looking at addressing barriers to positive outcomes, one of the things that we thought was important was promoting behavioral health integration. And from my perspective, that means bringing primary care services into the behavioral health spaces. So substance use disorder treatment clinics having not only on-site addiction medicine providers, but providers from other specialties as well, including psychiatry, internal medicine, family medicine, OBGYN and emergency or maybe not emergency medicine, but urgent care services, so that there was integrated addiction treatment, which has been shown to increase and improve outcomes. When we're looking at special outreach to older adults, making sure that we're screening those who are over the age of 55 about their substance use disorders, so that we can identify this older population and thereby refer them to treatment when they need it. Certainly, when we talk about the effectiveness of methadone, I would like to think that this is an informed audience. However, just a reminder, methadone has been around for a very, very long time, and it works. It has always worked, and it continues to work. It decreases opioid use. It decreases overdose deaths. It decreases criminal activity and risk of transmission of infectious diseases, and people are much more likely to stay in treatment when they're on this medication. And then also looking at buprenorphine. Buprenorphine is also a highly effective medication. It reduces overdoses at 3 months and at 12 months, and it certainly reduces the rate of emergency services for people who are using buprenorphine as well. So these medications do work. The unfortunate part is that despite the fact that we know that these medications work, only there's a small percentage of people who actually initiate evidence-based treatments. There's the data varies depending upon who it is that you're looking at. Historically, it's always been that only 10% of people who had substance use disorders access treatment, and that's probably true for substance use disorders overall. We've done a better job when it comes to opioid disorders. However, only about 25% of people who have opioid disorders access treatment. And so we're not at the 10% for all substance use disorders, and that's predominantly talking about largely alcohol, because that's the bigger problem that we have as a nation. But for opioid disorders, we're doing better than we're doing for alcohol, but we still have a long ways to go. When you look at people who are incarcerated, when people who are uh, released from incarcerated situations are treated with medications, they have the same benefits of decreased opioid overdose deaths as the general population does. And this is just a 1-year study done in Rhode Island, looking at the implementation of their medication-assisted treatment program. And the verbiage may have changed since then. However, the medications still do work when people are being released from jail. It really does help to save lives. And then reducing stigma overall. So one of the ways that we can do that is, again, talking about how it is that we talk about people who have these problems, looking at using person-centered language. So we're talking about a person who has a substance use disorder and not, an addict. Or a cocaine user or a methadone user. We're talking about a person who's methadone user, let's say fentanyl user. We're talking about a person who is using fentanyl, an individual with an opioid disorder, and not a disease. We're not treating a disease, we're treating people. And then also looking at our own implicit biases, which we all have. And how it is that we talk about individuals, how it is that we talk about communities, again, because that does impact how it is that we react, how it is that we respond, what it is that we do when someone's sitting across from us. We have to make sure that we are creating a safe environment for people that we're taking care of, that we have to, one of the most important things that we have is our therapeutic alliance when we're working with individuals. And so we have to look at how it is that we improve that therapeutic alliance and thereby positively influence people to follow our recommendations. And one of the things that we also have to look at is there is a significant stigma in the Black community about medications for the treatment of opioid disorders. And what we can't afford to do as a healthcare provider community is to be lackadaisical about other people's stigmas. If you had someone who has asthma, and they didn't like the concept of using an inhaler, we wouldn't say, well, it's okay, you don't use your inhaler. No, we would, vehemently and vigorously try to convince them to use an inhaler so that they don't die if they have an asthma attack. We have to do the same thing when we're confronting people who have uninformed understandings about medications when it comes to treatment of opioid disorders, and not be lackadaisical and say, okay, well, it's okay that you don't want to use the medication for the treatment of your opioid disorder. No, it's a point of engagement to say medications work, and the best thing that I can do, the gold standard of treatment, is for you to use a medication for the treatment of this disorder. It is effective. Let's talk about the side effects. Let's talk about the benefits of the medication. Let's give it a try, as opposed to just allowing people to just walk away and die. That I think is something that we really have to do a better job of. Talked a little bit about language, and I think you all will have the slides talking about how it is that we talk about individuals. Sometimes, people will use words to describe themselves that are derogatory and pejorative. I would encourage us not to use those words, even though we oftentimes talk about using an individual's language to talk about something. Yes, we can use our language to talk about something, but we don't have to use our language when we're talking about them as an individual. So when I'm encountering patients and they say that I'm an addict, that's their words and they can use that word, but I would never say you're an addict. I would say you're a person who has a substance use disorder because I'm trying to help them confront and manage and deal with their own self-stigmatizing attitudes towards these problems as well. When it comes to the criminal justice system, I'll just skip this slide because we're not talking about that environment so much. So we do certainly know that it's important that we increase harm reduction and that we support people identifying programs where they can go to get the support that they need while they are making the decision or as they're making a decision about what they're going to do about their substance use disorder. And so if you have a patient who or an individual that you're seeing who has a substance use disorder and they're not ready for treatment, then are you telling them about the syringe services program? Do you know about the syringe services programs that are near you? Do you know about where it is that they can go to get support for their addiction so that they don't die while they're waiting or as they're making their decision about what they're going to do and over the long haul with regards to their addiction? And most people make the decision to stop using drugs. They might not make that decision in the moment when you want them to, but most people do try. And so if you're not able to help them in that moment, then refer them to individuals who are able to provide that support. And so I'm going to stop here and just say that the barriers are real. The disparity is real. It's growing. However, it can be dealt with. We don't need to throw our hands up and say there's nothing we can do because the reality is there's a lot that we can do. And I do believe that it's all of our jobs to advocate to address this disparity as a field of justice-oriented deliverers of healthcare services. And I have the naive belief that healthcare providers really do and really are justice oriented because we really should be, and I think that we are fighting for the life and the health of the people who come to us for care, fighting for them. And so it's our job to do this work and to do what is right and to strive for what is right and the caretaking of other individuals and doing no harm by what it is that we do and also doing no harm by what it is that we don't do. As an addiction treatment community and as a healthcare provider community, we don't back down from a fight. And so I would continue to support and encourage us to remember the challenges that confront African Americans who have opioid use disorder and to commit to supporting and saving the life of every individual that it is that we can, no matter whose life that might be. And with that, I say thank you. Thank you for inviting me to be a part of this conversation.
Dr. Jones, thank you so much for that very important and thoughtful discussion. I'm assuming we have questions and maybe comments that will come in. I invite everyone to use either the Q&A box or the chat. Perhaps there will be someone who wants to come off mute. I'm watching the chat for you now. Dr. Jones, I'm happy to facilitate and pass those questions to you. So feel free to use either the Q&A or the chat or raise a hand and we'll invite you to come off of mute. Dr. Stoller. Yep. Pass it to you.
Yeah, thanks so much. First of all, I just want to really thank Max and Dr. Jones so much for providing this training. I think they'll be tragically harder to find moving forward. Some of you might participate with the PCSS and not because of their decision, but they're not going to be able to provide trainings like this moving forward, and it's terrible. But there's this one point I want to make, and that in addition to stigma against MOUD, there's this interesting new type of stigma that's being promoted recently that I think sustains these health inequities. And it's stigma against counseling for substance use disorder. There's these false narratives that are commonly being promoted now about counseling, chasing people away from treatment or being ineffective or promoting approaches that marginalize or even would dismantle comprehensive treatment, integrating medications and counseling like opioid treatment programs. And I mean, the problem that I see is that although some people who have addiction might adequately be treated with just medications, and leading to for them an improved quality of life, even more are not. And medications can't address a person's experience of systemic racism or past traumatic exposure or co-occurring disorders or a lack of societal support or housing insecurity. So, like in summary, I'd just like to suggest that we all avoid blindly accepting approaches that don't encourage treatment systems and providers that provide comprehensive, empathic, compassionate, individualized care, including not only MOUD, but also counseling and case management and behavioral interventions that address the barriers causing these race-based disparities to continue.
Yeah, well, Ken, first of all, thank you for being here. It's always good to be in spaces with you. And I completely agree that treatment is more than a medication. There's no question about that. I do think that counseling is very, very important for people. I think that, part of the reason, well, so the only benefit I see from the separation of counseling from treatment is from a barrier removal perspective, right? And so when we have individuals who are in treatment who can't participate in groups, who can't for one reason or the other, or in individual counseling, that used to be, well, you can't have care here because if you don't do our group, if you don't see the individual counselor, you don't have access to medication. And that was making, and from that perspective, I think that what we've learned, what the studies have shown is that whether people have counseling or not, that they still can benefit from being on medications. So I think it becomes how do we help to support people to recognize when a medication is not enough, because for some people it may be, but for some others it's not, and maybe and for some people they might not need counseling at one phase of their recovery journey, but they might need counseling at another part of their recovery journey. And so, how do we educate people about what are the forms of treatment? When do they need to use the forms of treatment? And just making sure that we're not erecting barriers to care, which I think that more often than not, the requirements that we had around groups became more of a barrier to care than they facilitated care.
Right. So I agree 100%. We need to learn how to motivate people to attend these other services, as opposed to just accepting that if people don't want it in the moment, then just leave it at that. We're behavioral health experts, and so we sort of know how to help to tip the scales in a positive way and encourage people to get what they need.
And
I
I
totally
think,
agree.
and from my experience, I find that it's how do we stay connected, right? How do we continue to work with an individual through this recovery journey that they're on? And I certainly have seen, in various ways that I have worked, whether I've worked in a clinic or whether I've worked in private practice. Someone might not be willing or interested in doing something right now. Like, okay, well, but you are willing to do this. You do want the medication. Let's do that. But then as the weeks and the months go by and our relationship continues to grow and I know them better and I start knowing the challenges and the problems that they're facing, it's like, okay, I really do think that you really need to talk more about this particular issue or problem. You need to address more of the relationship issues that you're having. You need to talk about why you're having a hard time at work. We can't do this in this medication visit, but I can refer you to this program or to that program or to this counselor or to that group, so that you can grow in these other areas that are important for your recovery. But I can't have that conversation with you if I don't see you. And medications are a way of keeping people engaged in treatment as you're helping them to sort these other things out.
Thank you, Dr. Stoller and Dr. Jones. I'm scrolling the chat. I see a comment that this was an excellent presentation and very informative. Anyone else want to come off mute or add a question to the chat? I'm happy to tee that up for Dr. Jones. We'll give it another minute, perhaps, so that there's space for that.
So this is the one time my being from New Jersey and speaking very fast. My I would try to make sure that we had enough time for questions. So I hope everybody could understand me.
Well, I think so. I see an introduction coming in. Well, I will remind the group that if you do have questions, clinical questions or policy related questions, you can always call our warm line or email and reach out. We're happy to connect you with one of the addiction medicine consultants on our team. If it's something that we need to reach out to Dr. Jones about, we maybe could do that on the back end if it's beyond what our team can handle. We are really grateful for the time you took with us, Dr. Jones, and everyone else who joined in. We have put lots of information in about how to connect with IT, how to get your credit. If you have questions about that, feel free to reach out to us. We recorded today's webinar and we'll make the information available through our website, typically within about a week. So thank you again for joining us, Dr. Jones. We appreciate your time as well this afternoon. So enjoy the rest of your day.
Thank you all.
Take
Be
care.
well.
Bye-bye.